As far as non-vascular is concerned, it's endless. It can be a biopsy, a drainage of any collection. You could do fallopian tube recanalization, antenatal interventions, biliary interventions. The entire GIT can be intervened. The tract, urinary, you could do urethral dilatations, ureteral dilatations. You could do skeletal interventions, pain management, ablation of varicose veins, ablation of metastasis, tumors. I mean, it's really endless. The best part about interventional radiology is that any intervention that you can do in the body utilizing ultrasound, CT, MR, fluoroscopy, DSA is in the purview of interventional radiology. Now, if we talk about materials, the bare minimum that we should know is the needles, the guide wires, the sheaths, the catheters, maybe the closure devices, and a few more things as we go down. As far as needles are concerned, a needle is a hollow metal tube which is sharp at its distal end. That is what is a needle. And through this needle, you can pierce into the body, reach a particular part, and this needle can be used to inject something or pass a wire. Anything which is not hollow is not a needle. Anything which does not have a sharp tip is not a needle. So please remember this. So if you have a needle and if you make the distal tip blunt, it becomes a cannula. If you have a needle and you fill the lumen with metal, it becomes a stillet. So a needle is something which is hollow and has sharp tip. Now the various needles that I can think of that could be put on the table, which will make sure that you pass, are a lumbar puncture needle, an arterial puncture needle, some biopsy needles. Now what is a lumbar puncture needle? Lumbar puncture needle on an average is about 9 centimeters long. Some of them are even shorter, 7 centimeters and 5 centimeters if you're going to use it in children. But for passing, we should know that these are 9 centimeters long. These are thin needles. The usual needles that we use are 22 gauge or 23 gauge. In the pediatric population, even a 27 gauge LP needle is used. But in radiology, when we use a lumbar puncture needle to access small fine collections or to deliver agents such as alcohol, we usually use a 21 to a 23 gauge. Usually it's a 22 gauge. Now, when we come to biopsy needles, in fact, the LP needle is also most commonly used for the fine needle aspiration. If you have to take a small piece of tissue, that is when we talk about a biopsy needle. And the biopsy needle, if you see this needle, this is the one which is most often used, in which you can see a shelf. This is the tip of the needle, and this is the outer needle. So this is the needle. The stillet of the needle has got a space in which the tissue gets captured. So in the tissue, this needle goes in first, and it is followed by the stillet goes in first, and the needle actually comes over it. And whatever tissue has come in this part of this device gets trapped inside. And that's how we get the sample. Now, these could be manual, in which there is no spring involved. All steps are done manually. But what we usually use is this semi-automatic. In this semi-automatic, you've got to pull back the stillet. And then you fire. And this is automatic. Once you have loaded by pressing 2 buttons on this side and you fire, both the steps occur simultaneously. But if you say that this is a true cut biopsy needle, automatic for both of these, the answer is correct. And if you have no spring mechanism, then it's a manual true cut biopsy needle. Apart from a true cut biopsy, we could get a core biopsy needle. In a core biopsy needle, there is no shelf like this. There's a needle, there's a stillet inside. The stillet does not have a window or a space to collect a specimen. So imagine if this was solid like in this. So what we do is we remove the stillet once we have reached the location and only pass the needle into the tissue. This is what is usually done when we do a bone biopsy. We cannot use this in the bone. We have to use a core biopsy needle. So this is what, as far as materials is concerned, we need to know about needles, essential. We delve a little more into the needles. This is what is a regular arterial puncture needle, but this could be used even for a venous access. This can also be used for accessing any cystic collection. The arterial puncture needle classically is 18 gauge in thickness, and the length from this point to this point is 7 centimeters. This is all you need to know about an arterial puncture needle. 9 centimeter, 18 gauge. Then you can, yeah, Joyce, any question in between? Okay.
Not yet, sir, not yet.
Okay, fine.
I'm keeping a watch on the chat box, sir.
Okay, fine, sure. Now, there can be a needle which will look like an LP needle. I said an LP needle is 9 centimeters long. It will be as thin as an LP needle, but it will be really long. It will be maybe 15 centimeters, maybe 20 centimeters. This is what is a Chiba needle. And this is used for accessing the dilated intrahepatic biliary radicals. So this looks like the LP needle, but the LP needle is only 9 centimeters, and this is going to be really long. So if you see an LP needle which is really long, it is a Chiba needle. Next, we come to wires. Now, guide wires during an arterial access are passed through this puncture needle. And once the guide wire is inside the vessel, that is when we remove the needle. Now, you may come across wires which will be kept in a, this is what is known as a hoop. They could be out of it also. What is important to know is that a guide wire could be as short as 23 centimeters. This is what is used along with the vascular sheath during an arterial access. But when we have to place catheters, our usual angiographic catheters are about 90 centimeters, 100 centimeters long. So the guide wire has to be longer than that, and these are usually 150 centimeters. If you have to exchange a catheter, the wire becomes 260 centimeters because it has to be inside the body, at the same time be longer than the catheter, and still you should be left out with some part so that you can hold it. So to exchange any catheter, the wire has to be more than twice the length of that catheter. Please remember this. So an exchange wire starts at 260, it could be up to 310 centimeters or more. So please remember, anything which is about 1.5 meters is a regular standard angiographic guide wire. Now these guide wires could be two colors. They could be green or a bluish green. These are Teflon coated. Though these are also hydrophilic, I would say these are marketed as hydrophilic, but as an interventional radiologist or as a radiologist, we do not accept them to be hydrophilic because we have something which is absolutely hydrophilic, which is coated black, what we call as the Teremo wire, because that is the company which has been marketing it for quite some time and has got a monopoly, and there's no other hydrophilic wire as good as it. So these are going to be black. So these are hydrophilic, and the others are Teflon coated. Now, the next thing you should know about a guide wire is how is the tip. The tip could be straight, it could be curved. If it is curved more than 90 degrees, this is known as a J-tip. If you see, this is like a J, the J type catheter guide wire. Anything in between the straight and the J is an angled guide wire. This is the bare minimum essential that we need to know about guide wires. They could vary in length. They could be Teflon coated or hydrophilic. And we should know that there are different tips. A little more about guide wires. The thickness of guide wires varies. These are angiographic guide wires, varies from 0.038 inch to as thin as 0.08. There is one odd wire which is also 0.007 inches thick. Actually, I should use the word 0.007 inches thin. These are very, very thin. 3.8, 3.5, we also have 2.5 in between, but please remember these are regular guide wires. Anything which is thinner than or equal to 0.018 becomes a micro guide wire. As far as lengths of these are concerned, again, they could vary from 150 centimeters to up to 350 centimeters, depending on whether these are used only for access or these are used as a guide wire. In this example, these are the regular angiographic guide wires. The thin wire that you see, this is what is a micro guide wire. A micro guide wire would be very, very floppy and would be almost as thin as a hair. Then we move on to the next essential item, which is known as a vascular check flow sheath. This is the technically correct name for this. This is a sheath, but this is a vascular sheath because we use it in the blood vessels, and it checks the flow because there is a valve over here. That is why it is known as a vascular check flow sheath. These sheaths are classically about 11 centimeters long. Anything longer than 11 centimeters.
No.
Sir, I think some problem. I'll just come back to you, sir.
Yeah, sure.
Kindly mute yourselves, whoever has not yet done. So please carry on, sir.
Okay. So we were on vascular check flow sheath. The regular check flow sheath is 11 centimeters. If it is less than that, it is known as a short sheath. If it is longer than that, it is known as a long sheath. A long sheath could rest in the common iliac or into the proximal aorta as we are accessing through the femoral artery, or these could reach into the arch of the aorta, or these could also reach into the common carotid artery. So depending on what level of support that we want for the catheters, we need to choose the sheaths. Now, so this is what is a vascular check flow sheath. Almost every third student is going to be asked about this. These also come in various sizes of 4 French, 6, 5, 6, 7, 8, 10, 12 French. And this, the French size denotes what is the size of a catheter that can go through the lumen of this particular sheath. So when we talk about size of a sheath, when we say 6 French, it is the inner diameter of the sheath, and a 6 French catheter can go through it. Next, we move on to catheters. Catheters are something like this, long tubes. A usual diagnostic catheter is 4 French or more. They are usually 4 French, 5 French, or 6 French. And when we talk of catheter, it is the outer diameter of the catheter, which is in French. And when we talk of sheath, it is the inner diameter of this sheath, so that we know that that particular diameter catheter or size catheter can go through it. The catheters could be diagnostic when they are 4 French or more. They could be micro catheters when they are 3 French or less. They could be infusion catheters, both diagnostic and micro. when they have multiple holes in their distal part so that a liquid medicine can be infused through it. Now there is something known as a diagnostic catheter and there is something known as a guide catheter. Now this is one difference that we should know about. In a diagnostic catheter, the diameter of the tip of the catheter is less than that of the shaft of the catheter, so that they become atraumatic. As far as a guide catheter is concerned, this is a catheter through which we put microcatheters. We can even put diagnostic catheters through it. The tip of a diagnostic catheter is narrower than the shaft, whereas as far as the guide catheter is concerned, you will see that the tip is parallel. So that is what is a guide catheter. And these are what are diagnostic catheters. If you see, there is a subtle difference between the thickness over here vis-a-vis the tip. The tip narrows down. If you look at here, this diameter is more, the tip is narrowing down. The diameter is more and it is narrowing down. All these catheters, the moment you feel them with your finger and the thumb, you'll realize that these are narrow. Now we come to shape of the diagnostic catheters. There are a few shapes which are invariably asked. The three most commonly asked are the headhunter. If you see that there are two bends, but the tip is still pointing away from the catheter, this is a headhunter catheter used for accessing the carotids, internal, external, common carotid, and even the vertebral could be accessed through this. Then there is a catheter which is like the cobra's hood. It is turning on itself. This is what is known as a cobra catheter, and this is used for accessing the visceral vessels like the celiac artery. This could also be used for accessing the renal arteries. This is one of the very friendly catheters. If there is a catheter which bends on itself, here it is only curved on itself, here it is bent on itself. These are known as reverse curve catheters. If this reverse curve is as short as this, about 3 to 5 centimeters, this is a Sims catheter. But if the same thing is bent, long bend, that becomes a Roberts uterine catheter. So the two reverse catheters that you would be asked in the exam would be a short bend, that is the Sims catheter, and a really long bend, about 10 to 12 centimeter long bend, that will be Roberts uterine catheter. And this is an angle tip catheter. This is also known as you could even call it as a multi-purpose catheter because it has a very gentle bend and is quite versatile. If this catheter is absolutely straight, it is a straight catheter. So if you know the shape tips of headhunter, cobra, Sims, a long Sim known as the Roberts, a multi-purpose and straight, that is more than enough. There is another type of diagnostic catheter which has a tip which is bent on itself like the pig's tail. Let's just see how is it seen. Pig's tail, and this is known as a pigtail and an angio catheter or an angiographic catheter. The difference between a pigtail angiographic catheter and a catheter which is used for draining abscesses is the length. A pigtail catheter which is used for draining abscesses and cysts are 15 to 30 centimeter long. They are thicker, whereas the pigtail catheters which are used for angiographic access are at least 60 centimeters long and usually they are 90 centimeters long. Now if you notice over here, the pigtail catheters which are used for flush aortograms usually have holes in the distal tips. You can even have a pigtail catheter with multiple markers which are at 1 centimeter distance to measure the distance of a lesion, especially like in an aortic aneurysm. So these become the marker pigtail catheters. If they do not have this marker, they are regular angiographic pigtail catheters. And these, because these are diagnostic catheters, these are again between 4 to 6 French in diameter. Microcatheters. Microcatheters, as you can see this particular image, will actually roll and fold on itself. They are really floppy. Vis-a-vis a diagnostic catheter, these are quite firm and they will not bend on itself. Whereas this particular catheter, you cannot lift it up straight. It'll roll and bend on itself. These are microcatheters, and these are usually about 1 millimeter thick or less than that. And the diagnostic catheters are about 2 millimeter thick or so. As far as microcatheters are concerned, one more thing that we should know is that these could be microcatheters with 2 distal radiopaque markers, or
Just a minute, sir. I'll just check. Please ensure everyone is muted. Yes, sir. Please continue, sir.
okay. Now the microcatheters, as we learned that microcatheter is a catheter whose diameter is less than 3 French. The usual microcatheters which are used in neuro are much thinner, whereas the ones which are used in the peripheral parts of the body, like the prograde catheter, are around 2.7 to 3 French. The usual ones that are used in neuro are between 1.5 or less to 2 to around 2 French. Now the microcatheters could be a flow-guided microcatheter, which has only one marker, which is used for accessing arteriovenous malformations. They are very floppy, and they, by virtue of being very floppy, they are difficult to position, but in a high flow situation, these are the ones which are also carried by the flow, or the flow assists in carrying them to the lesion. And that's why these are known as flow guided. Vis-a-vis catheters which are used to put coils in aneurysms, they need not be floppy, because if they are floppy, they will not support the coil while it is coming out, and they will back out. So these are firm catheters, these are slightly thicker, and these are relatively rigid. And you will see that there are 2 marker bands, one at the tip and one 3 centimeters proximal to this. The purpose for this band is because as you start filling in coils inside the aneurysm, the distal tip of the microcatheter will not be seen. This is one will help us tell us that, well, the microcatheter is still in its position. Secondly, the detachable coils that we put into the aneurysms, there is a marker which comes over here, a black marker on the wire. When that marker has just beyond this proximal marker, the marker band on the coil that we are detaching, when that reaches here, we know that the entire coil is inside the aneurysm and we could detach it. So these are the 2 reasons why a microcatheter which is used to put coils inside an aneurysm has 2 distal markers, whereas we need not have that in a flow-guided microcatheter. And I think this is all that we need to really know about microcatheters to ensure that we pass without doubt. This is the guide catheter that we spoke about, and depending on which anatomy that we want to put, the guide catheters could be multi-purpose, could be angle tip, or they could have shapes similar to the diagnostic catheters. The only thing you remember that when you move your fingers in the distal 2 to 3 centimeters, the diameter of this catheter is the same as its tip. So these are the guide catheters. Another category of catheters are balloon catheters or the angioplasty catheters. Now these could be microcatheter with a balloon, or there could also be a diagnostic catheter with a balloon. So the peripheral angioplasty catheters are as thick as the diagnostic catheters, and they have a balloon at its distal tip. Whereas balloon guided catheters, which we use for intracranial circulation, are microcatheters as thick as the microcatheter, and they have balloons at their tip. But as long as you can say that these are balloon catheters And the ones which are as thick as the diagnostic catheters are used for angioplasty. That is good. Microcatheters with balloons, usually they are used for balloon assisted coiling. And if you answer this much, that is really good enough. Another set of catheters are known as the HSG catheters, used for hysterosalpingography. These are short catheters, double lumen catheters. They have a balloon at the distal tip. These are about 15 to 20 centimeters long. So once you have positioned them into the endometrium with the help of a guide wire, we can inflate the balloon, and we can also inject. This is used for inflating the balloon, and we can also inject contrast through it. So the advantage of an HSG catheter is that this particular balloon prevents the HSG catheter from slipping out of the uterine cavity, and also arrests the outward flow or the backflow of the contrast. And if we use this, we require very, very minimal quantity of contrast. So this is what we need to know about the HSG catheter. Now, once we have accessed the artery, you may be shown what is known as a closure device. The closure device broadly are two types, a suture-based and a plug-based. What is seen over here is angio-seal, which is a plug-based. So what happens is, inside this, there is a gelatin plug which goes and seals the access site in an artery, and we don't have to give prolonged compression. In fact, you need not even compress, but for safety, we do press it for about 5 minutes, and the patient can be mobile as early as 30 minutes after the procedure. The other type is a suture-based. The one that we use in our country is ProGlide. So please remember, if you're shown something like this, on which it is written ProGlide, this is a suture-based closure device. If you're shown AngioSeal, then it is a plug-based closure device. And that's all that you need to know. So while removing the vascular sheath, what we do is we access the artery with a puncture needle. We use a guide wire to get into the vessel, remove the needle, and then we use a vascular check flow sheath. And through this sheath, we pass the diagnostic catheters with the help of guide wires. And once we have done the procedure and we remove the diagnostic catheter, before removing the sheath, we put back the guide wire. On the guide wire, we use one of these two closure devices. So we have the guide wire at the end of the procedure in the artery. We remove the sheath, and over the guide wire, pass the closure device, remove the guide wire and use the closure device and plug the hole in the artery. So this makes life both for the interventional radiologist and for the patient comfortable. What's the time? Okay, we are halfway through our time that we have. Now you may be shown something which looks like this. There's a diagnostic catheter or a microcatheter, and then there's a wire which comes and there's a loop around here. This is what is known as a snare, an endovascular snare. In case if the catheter tip breaks inside the body, or if there is a coil which is detached in a place or not well detached and we want to pull it back, this is what is used. At times, when a central line is placed in the ICU by a person who's not very well versed with it, the guide wire can be pushed into the jugular vein or the venous system. That is when your help may be required to take out or snare out any foreign body from within the vascular tree. So this is what is a endovascular snare. If it is used through a microcatheter, it is a micro snare. Otherwise, it's a regular snare. Drainage catheter we spoke about. The usual drainage catheters we use are between 8 to 10 French, whereas the angiographic pigtail catheters that we use are 4, 5, or 6 French. So these are thinner. The abscess drainage catheters are thicker, and these are short, between 15 and 30 centimeters. A pigtail catheter could come with a stillet inside so that we can straight away poke into the abscess, or we can use the Seldinger technique if we have a catheter which does not have the stillet. So this is about the drainage catheters. Then we come to stents. Now, stents, as it stands, are all made of metal. They could be steel, they could be nitinol, they could be cobalt, chromium. So if you know that the stents could be made of steel, nitinol, or cobalt, chromium, that is good enough. As far as steel stents are concerned, these are not self-expanding. Nitinol stents are the ones which are self-expanding. Cobalt, chromium are also not self-expanding. Now, in stents, we need to know two differentiations. One, does it expand on its own, or does it require to be loaded onto a balloon, and a balloon needs to be inflated to expand the stent to its desired size? That is what determines whether it's a self-expandable stent like this, or it's a balloon expandable stent like this. A self-expandable stent is loaded inside a delivery catheter, whereas a balloon expandable stent is loaded onto a balloon like this. So that is the difference between a self-expandable and a balloon expandable stent. Where we require absolutely precise deployment of a stent, we use a balloon expandable stent. Where we can afford to use a long stent, we use a self-expandable stent. So that is one major difference between a balloon expandable and a self-expandable. Another difference between a balloon expandable and self-expandable is a self-expandable stent which is made of nitinol has its own memory. Even if you press it and release it, it will come back to its nominal size because it is self-expandable. But if a balloon expandable stent, if it has been deployed in the body and for whatever reason it gets pressed, this also will get pressed like this. So a balloon expandable stent is used in the inner parts of the body which are not compressible from outside, like the abdomen, whereas in the neck, which can be compressed, we use self-expandable stents. Another category of differentiation of stents could be, the stents could be bare metal stents, or the metal part of it could be covered by a fabric when it is known as a covered stent, or it could be hybrid stent where a part of the stent could be covered and a part of stent could be uncovered. Now we used covered stents whenever we need to reconstruct the blood vessel, like in an aortic aneurysm, or if we want to block a pseudoaneurysm, that is, wherever we have put a stent, we do not want the blood to leak out of the stent struts. That is where we use a covered stent. In rest of the places where you want only to open the lumen of the vessel, we use a bare stent. The disadvantage of a covered stent is that if there's a branch which is coming from here, that will also get blocked. The advantage of a self-expanding bare stent is that when you deploy it across a branch, the blood flow in the branch will continue. So these are used for stenosis, these are used for aortic aneurysms and for pseudoaneurysms. This is an example of a hybrid stent where a part of the stent is covered and a part of the stent is not covered. Though you see here a part of the metal which is not covered, but these are only anchors. If you see, there are some sharp thorn-like structures here. These are only anchors. The actual stent is from this part to this part. Whereas in this entire part device is a stent, and this is used for transjugular intrahepatic portosystemic shunt. The bare stent is used into the portal vein. whereas the covered part is used inside the parenchyma of the liver so that we prevent the liver to grow into these, through this, prolapse through this struts and maintain or prolong the longevity of the stent that has been used for creating a TIPS, transjugular intrahepatic portosystemic shunt. I think this is all that you need to know to pass and sail smoothly through the table Viva as far as stents are concerned. So this is how a stent is placed. My mobile. Okay, there is another category of stents which are with us for less than a decade now. These are known as flow diverter stents. These are a hybrid between a covered stent and a bare stent. These are actually bare stents, bare stents. They do not have a fabric on it, but the mesh of these stents are so closely knit that they allow very little blood to pass through the struts, and they divert the blood through the lumen of this stent. Because they divert the blood through it and minimize the amount of blood which is flowing through these struts, these are known as flow diverters, and these are used predominantly in intracranial circulation for internal carotid arteries where there are wide-necked aneurysms. So this much about the flow diverter stents. Then we come to embolic agents. Embolic agents could be liquid or particulate. Embolic agents are used to block or occlude something. So these could be powder particles. This could be solid or liquid. Solid could be particles or coils or gel foam. These pieces of gel foam come as a sheet, and then we got to cut them into small pledgets. These are gel foam. This is a temporary embolic agent. Gives you benefit for up to 2 weeks, and it starts getting dissolved in about 3 days onwards. So if you want a longer lasting effect, we need to use sort of permanent embolic agents like the polyvinyl alcohol particles. Embolic agents could also be coils. The coils which are used in aneurysms are bare coils. The coils could also have fibers so that it becomes very, very thrombogenic. So these are used in peripheral circulation where we need to occlude a blood vessel which has ruptured very, very fast. We could also use liquid embolic agents like the glue, or the another one which is a black liquid known as Onyx. A glue is a very, very rapidly setting or occluding liquid, whereas Onyx takes a little time. Glue causes inflammation to the adjoining wall, and hence it also causes spasm of the vessel. It damages the vessel also while it is occluding, whereas Onyx that way is inert. It's a filling agent. It is a liquid embolic agent which fills the malformation, and that is how it acts. The advantage of Onyx is it gives us about 20, 25, 30, 45 minutes before it can solidify fully. As far as glue is concerned, NBCA, N-butyl cyanoacrylate, it's instantaneous. As far as particle agents are concerned, there is also one category of something similar to PVA particles. These are drug eluting beads. These are gel beads, and they can soak into them a chemotherapeutic agent. So the advantage is when we put them, let's say in a hepatocellular carcinoma, they get deployed inside the tumor, and very gradually they chelate or diffuse out the medicine that has been absorbed or adsorbed into it. And that is why these drug eluting beads are used as for delivering a chemotherapeutic agent like doxorubicin in hepatocellular carcinoma. As far as coils are concerned, they could be detachable or pushable. This is an example of a pushable coil. It is free at this end. You just push it through a catheter which has been placed at the lesion. And these are detachable coils. That means we detach this only once we are sure that this particular coil has rested in the desired place. In a pushable coil, once it is pushed out of the diagnostic catheter or a delivery catheter by more than 1/3 of its distance, or maybe 50% of its distance, you just cannot do anything about it. In fact, the safety guidelines say that the moment you are out of the catheter, you may deploy it while you are withdrawing the catheter. So these cannot be retrieved, and we have to be very, very cautious when we are using these. Whereas detachable coils, as you see over here, there's a detachment point over here. These can be repositioned a couple of times, and if you're not happy with it, you could actually withdraw it out of the body also before it is detached. So by and large, in neuro work, we use detachable coils so that we deploy it in the body only once we are certain that it's in the right place. Peripheral circulation, because it is rather forgiving or could be more forgiving, we use pushable coils. But given a choice, if we could either use pushable or detachable, and the patient can afford or your organization can afford, we would rather use a detachable coil rather than a pushable coil. Now these coils could be 2D coils, this could be 3D coils, they could be simple helical coils, this is a helix, or these could be complex. So they could be 3D. 3D is a type of complex coils. In this 3D also there can be further complex coils. So if you see a coil which is only circles and circles, it's a helical coil. If the last loop of this coil is smaller than the distal most loop is lesser in diameter than the proximal most loop, it's a 2D coil. If it's a complex, like a ball, then it's a 3D or a complex coil. So that much about coils. Now what's the time? Okay. So we move on to a few more things. You may be shown this. You may be shown a basket. A snare had only one loop. It could be 1 or 2 loops, but something which is similar to this and looks almost like a basket is for stone extraction. This can be used for extracting stones from the common bile duct or even from the ureter. You may be shown an injector like this, which is used for vertebroplasty. So if you say, sir, this is an injector for vertebroplasty, that should be more than enough. You may be shown a needle which has stillets coming out like this. This is a starburst needle which is used for radiofrequency ablation of solid tumors such as the liver tumors or renal tumors. So if you see a needle like this is a starburst needle of radiofrequency ablation. If you do not have burst of stillets coming out like this, and you only have a needle with 2 marks like this, then it's a radiofrequency ablation needle. Unlikely to be shown. If at all shown, you would be shown something like this because this is rather distinctive. Okay. Something else that you could be shown is a vial of sotradicol or a polidocanol. This is a sclerosing agent. We create a foam of this with almost equal parts of air and this liquid. We agitate them through 2 syringes connected with a 3-way, and this is how we generate foam. And this is usually used for occluding or sclerosing incompetent perforators. You see this flow in 2 directions, and once you have injected foam inside this, the flow stops. So what you could be shown is a vial of sotradicol or a polidocanol, and this is what is used to create a foam for occluding incompetent perforators and varicose veins. You may also be shown something like this, which is a filter, which is used in inferior vena cava. This is towards the foot end. In a patient who has got a peripheral venous embolism, like in DVT, and if there is a free-floating thrombus in the common iliac vein or more proximal to it further, a deployment of a IVC filter can be done just below the renal veins. So if you see something like this is an IVC filter. You could also be shown this. This is known as an inflation device. This is used to inflate the balloon of an angioplasty catheter. You see these angioplasty catheter? So at the proximal end of this catheter, we attach the inflation device, and then we can inflate it to the safe limit that is much below the rated burst pressure of a balloon. If we inflate it inadvertently more than that, the balloon can also rupture. So the inflation device is used for controlled inflation. What's the time? Okay, so we are left with about 13 minutes. So this class was on the essentials of various materials that you can be asked on a table viva. And this is by and large the entire gamut of what is kept on a table. And now we have another 10-12 minutes for any questions.
Thank you, sir. Actually, I was going through the chat box. There are a couple of questions there. Dr. Rishabh Bhatia is asking how many centimeter does a gun shoot in a semi or a fully automatic needle?
Okay, so the answer to this is these are available in different sizes, and the usual throw, we use the term as throw, is about 20 millimeters. There are also guns which are available which you could choose whether it fires 1 centimeter or 2 centimeters. So the usual throw is 2 centimeters. At least I haven't seen a needle which has a throw of more than 2 centimeters.
Another question from Dr. Natasha. What is the self-expandable stent made up of?
Okay. The self-expandable stents are all made of nitinol. They are not made of steel. They are made of a alloy nitinol.
Okay. These are a couple of questions I got in the chat box. Anyone else is free to ask sir any queries that you have. You can unmute the microphone and ask him the question. Anyone has any queries? The difference between self-expandable and balloon expandable stent.
Okay.
She just wants it to know once again.
Sure. Absolutely no problem. A self-expandable stent is made of nitinol. A balloon expandable stent is usually made of steel or of cobalt chromium. And a self-expandable stent can be used in carotid artery stenosis, because if we massage our neck, let's say while bathing, it will not get deformed permanently. It will get pressed and it will open again. Balloon expandable stents are stents which can be precisely deployed. That is the advantage of it. We can even control the diameter to which we want it to be expanded, whereas self-expandable stent, we cannot control that. As far as balloon expandable stent, the drawback is that if you put them across a joint, Or if you put them in a place like the neck, which can get pressed, these can get deformed because they do not have a capability of expanding on their own. Is that clear?
That must be clear to the. One more question was regarding how do we clean the catheters guidewires if they can be reused by Dr. Nidhi Agarwal.
Okay. Now, the answer is legally, we are not supposed to be reusing a material which is single use. That is the legal aspect. Now, in a life-saving situation, you're in a place where you do not have a material and all you have is old material which you have already used. At least I am convinced that if this is the reason and you have used it to save a life or a limb and there is no other option, the patient could not be transferred anywhere else. And if you reuse it, I am almost certain that the court of law is going to spare you. Now, having told this in background, how do we sterilize or clean a catheter or a guide wire so that it could be used again? This, number one, you should wash it very nicely with water. Make sure you do not scrub it because otherwise the safe coatings over them can get dislodged or damaged. After you're sure that it has been cleaned very nicely in water, you should let it dry and then soak it in hydrogen peroxide for about an hour or so. Again, wash it nicely. Make sure there are no blood clots. Make sure it is not bent or kinked. And thereafter, it is packed in a paper wrapping and then it is sterilized using ethylene trioxide, ETO. If the facility for ETO is not there and there is emergency, then there are chemicals which are available today. You can, such as Sidex, in which the contact time is supposed to be 30 minutes. There are others also which have come up in which the contact time can be as little as 5 minutes. So having told you the caution that you are supposed to use it, where you can justify that why you have reused it for the benefit of the patient. And if you have used a reused material, please do not charge the full price of the material. You are supposed to then preferably do it free of cost.
Many of them are asking about biliary stenting, sir. Basically, what are the types of biliary stent, PTBD procedure, and all. I think we can have a separate class on that from you, I guess.
Yeah. So as far as biliary stents are concerned, we use self-expandable stents so that it can cause some pressure on the tumor which is trying to ingrow. So we use self-expandable stents in PTBD. Yes, as far as procedure is concerned, yes, for procedures we can have another class, certainly.
And some of them are asking for any summary of the needles and all. We will just try and yes, sir.
Otherwise, we still have 6 minutes. Actually, I have a commitment at 7:30. That is why we have to hard stop at 7. Okay, summary of the needles. Yes, that is very important. I shall certainly go through it. The needles usually that are kept on a Viva table would be these or something similar to this. There could be a lumbar puncture needle, which is used for FNAC. There could be a true cut biopsy needle, a semi-automatic, a fully automatic, and a core biopsy needle. A lumbar puncture needle is a standard lumbar puncture needle for an adult is 9 centimeters, and they come in varying thickness from 27 till about 21 or even 20 gauge. The usual lumbar puncture needle that we use for FNAC is between 20 and 23. What most of us prefer is about 21, 22 gauge. If you have a needle which has a stillet and the stillet has a space like this, and it has a mechanism wherein you can first push the stillet into the tumor and then you can push the outer needle over it so that the abnormal tissue get trapped over here. This is what is known as a true cut biopsy needle. A core needle has a solid stillet inside. So what is done is, with this stillet inside the needle, we reach the lesion. Once we have reached the lesion, a little into the surface of the needle, we remove the stellate and then only push the needle into the tumor so that the tumor gets inside the lumen of the needle and we get a core of tissue. Because here the tissue is cut by the needle, it is known as true cut needle. And because we get a core of tissue and not a sliver of tissue, we get a core of tissue in the needle. These are known as core biopsy needles. This is what is an angiographic puncture needle, which will be 18 gauge. And this length will be 7 centimeters. And if there is a needle which is as thin as a lumbar puncture needle, but is much longer than 9 centimeters, a 9 centimeter would be somewhere here, double than a lumbar puncture needle. This is a Chiba needle. And this is used for accessing dilated intrahepatic biliary radicals. This is a stopper over here. We can use this to place, depending on ultrasound, when we have seen that what is the depth to which we have to go, we can place it at that depth. And when we are putting the needle into the body, we'll know that, okay, we have reached that particular desired depth. And so that we do not cross the inner surface of the liver. I think this is what we discussed about needles.
Thank you, sir. I think those were the questions. And if there are any questions, they'll always come back to us on the email, and we will definitely get it back to you. And thank you so much, sir, for being with us here today. And we will love to have you again and again.
No, you're most welcome. Anytime, whatever you think I can be of any help, you're most welcome, Pendra. And all the best to all the exam going students. Wish you all the best. Right. See you. Good evening.
Thank you. Thank you so much, sir. Thank you so much, sir.
Right, Joyesh.
Yes, sir. So that was Dr. Hirdesh Sahni, sir. He gave an extensive lecture on the table Viva aspects of the interventions. And yeah, sure. We are having a feedback poll on this. So I'm just launching the poll. And before you leave this platform, just ensure that most of you have answered this. This is basically feedback that we are getting from you people, so that we can try and improve with every class. So please do it. And shortly we'll be having a spotter session by Dr. Harikiran Reddy. And just wait for a couple of minutes before we can actually start with it. Just hold on for a couple of minutes.